using patient preferences for that, that would be really interesting. And Simon, I'm going to ask you from the kind of perspective of a consultant who works with companies. Clearly, you were working at a stage where the company had failed with the first kind of reimbursement negotiations. You work in other sectors beyond health. Is there anything in the health sector we could be doing differently that we could learn from those other sectors rather than leaving it to the last minute to when we get a negative reimbursement decision?
Yeah, I think there is, Karen. I think it comes down to being a little bit more proactive in regards to generating that evidence earlier. So not leaving, if we think that there's some uncertainty around the decision, it is obviously good to go earlier to get that evidence and generate that. So not saying in this particular case for AstraZeneca, but I think overall, it's really good to have that. And so I think what we're seeing in terms of the work that we're doing, I'm seeing companies coming to us a lot earlier now. The planning phases, 18 months out to go. We need to identify patient preferences for a submission that might be a long way down the line, or even that we have a pipeline treatment that's coming out. And so I haven't seen the change even from when that study was done, probably 3-4 years ago, to what it is now. And obviously, it's a move in the right direction, because I think we need to be a little bit more proactive. And just on the other point, to Nancy's point about where they fit in the life cycle, I don't think we need to draw a line in the sand as to fitting them into one particular area, whether it's reimbursement, regulatory, post-market, R&D. There's actually a well-designed preference study can cover all of those. All of those areas can input as evidence. So you don't need to say, I'm just doing this for reimbursement, or I'm just doing this for post-market. If you design your study and you update it regularly, so if you were doing a preference study for myeloma and you did it every 12 months, not just in the UK, around the world, then we could actually see what do myeloma patients value, what's happening with the new treatments, the experiences that's happening to them, and it could feed into all of those parts of the life cycle. So I think that's something to think about.
That's really interesting. And now moving to Jacqueline, you mentioned there that NICE had done one sort of scientific advice process for patient preferences, and that's now becoming more of the norm. Do you want to tell us a bit about that process and why NICE has sort of taken that on board?
I think having completed the kind of the exploratory project that we did, I think we identified that a lot of companies are actually already doing these studies. We might not see them routinely as part of evidence submissions, but we know that they are routinely being done. So being aware of that, we just felt that scientific advice was kind of a natural kind of point of contact for companies to engage with NICE and get answer to some questions about how they could potentially make these studies more relevant. But that being said, we don't think that necessarily that's limited to only commercial companies. I think that a lot of patient charities and patient advocacy groups are interested really in this field as well, and we'd be happy to engage with them as well. I think it's kind of a a chicken or egg situation. We know that these studies are being done, but they're not really routinely being they're not part of the submissions yet, so, and therefore perhaps companies don't consider it, so we don't end up seeing them. So we thought that if we could add to that and perhaps break that cycle a bit by actually offering advice, which has been going, it's been proven to be well received so far.
Great. And just as a follow-up to that, and perhaps a question to the other HTA bodies, do you see, as a result of that advice, developing any general learning? So you have quite detailed methods guides for economic evaluation. Do you see NICE producing any methods guides for patient preference studies, or would you look elsewhere for those?
I don't think that that's something we're actively exploring at the moment. I could see that change, especially once we gain more experience. But there also are other groups, such as IMI Prefer, for example, that is doing work there. And I feel like perhaps what would be more useful would potentially to have kind of a comprehensive overview, bringing all the different elements together in a kind of an overall overarching framework. So even though if NICE doesn't provide that, there still is hopefully our resources out there and resources forthcoming out of some projects that could help advance that.
That's great. And so, Irina, tell us a little bit more. There was a question in the chat. Everybody's noted end of March 2022 as being the deadline for delivery. Will there be any sort of guidance coming out before that? And what will that guidance involve? Will that give, you know, a critical checklist for patient preference studies that can be used by anybody in HTA? What will that involve for the HTA doers?
Yeah, well, actually, the recommendations that are coming out of Prefer will be applicable to several kinds of stakeholders. So that's something to start with. So it will be targeted towards the industry, regulators, HTA agencies, but also patient groups. And we see different big parts in the recommendations. So we will present a framework for patient preference studies. So how to set them up, what to think about, what are patient preference sensitive situations. Briefly, what can, in what kind of context or situations can patient preferences add to the decision making. It will also tackle some practical issues, operational issues, what is required for setting up a good patient preference study, how can you assess a patient preference study? So what actually some kind of checklist, yeah. So that is also something that is still one thing that we would like to develop, is to develop some kind of checklist for assessing a patient preference study. And another part will be about, for instance, yeah, very specific things like should you use educational tools for patients who are going to participate in patient preference studies. Yeah, so it will be very broad, very large, and it will encompass very a framework as well as a checklist, and also points to consider when you select a method for preference elicitation, because the method that you choose will depend very much on the type of intervention that you consider, the type of population, the extent of the population. Is it for a rare disease or a very common disease? So there are many aspects that play an important role when setting up a patient preference study, and also by consequence the quality of a patient preference study, and again by consequence the usability of the patient preference study in the actual decision-making process. So it will, and another thing that is I think very relevant also is to see at which points in time patient preference studies should be performed in the medical product life cycle. And I talked about the very early phases, even maybe pre-discovery, but also what we will describe is what kind of patient preference study do you need for regulatory benefit risk decisions, for instance, and how do they differ maybe when you're talking about reimbursement decision making, because there might be differences in the kind of patient preference information that you need for these two types of decisions.
Thank you, Irina. And I think that's a really helpful context. We've talked a lot about discrete choice experiments within this webinar series, but that isn't the only methodology for undertaking patient preference research. In our book, we wrote about analytical hierarchy processes, which were also used in Germany at one point, and I'm sure there are other methods as well as more sort of qualitative research to more informally talk about patient preferences. And Nancy, I think I remember from your slides, you sort of said there was direct engagement with patients, there was qualitative research, and there was a preference study. Do you want to tell us a little bit more about those three different elements, if you can remember the details of them?
Yeah. So I think right now when we approach trying to determine the preferences and values of patients, we will always do direct patient engagement. And this is because we want to learn from folks in Ontario, where we're going to be making the reimbursement decision, what indeed is important to for their care. It is an interesting question of what will we learn from a qualitative versus a quantitative study. In this case, we did learn something unique because the quantitative study was a risk-benefit trade-off study, which is not the case. I mean, that's very unique in the amount of time that we've been looking at preference data, and it's been over the last few years, the published data. And this has probably been a very unique study to explicitly show the trade-offs, and it's great, and it really helped in this case. The qualitative evidence oftentimes gives us a peek into the impact of the condition onto the patient's life, what that experience is like living with it, where the burden of the illness is, and we find that the qualitative evidence really marries nicely with the direct patient engagement. And we find that there's a lot of triangulation that can happen with the data that comes out of that. I think as a whole, though, you know, one of the things we do is we try and get the information from wherever we can right now. So we can't always be sure it's going to be in a qualitative. We can't always be sure it's going to be in a quantitative. And we can't always be sure, as Irina pointed out, what type of quantitative evidence we're going to get. So it's a bit of a grab right now, which is, you know, a bit sad. And I think, of course, we're working to improve that. But I think the explicit differences in this case were the fact that we had a real unique study showing a risk-benefit trade-off. It doesn't always happen, and sometimes we don't learn a lot from the quantitative evidence that we've learned from the qualitative evidence or from the patient engagement. And I'll just say one last thing, in terms of doing direct patient engagement, when we do have published evidence, it really helps us determine what we need to seek answers and input from patients for. So that information in the published literature can help us guide our direct patient engagement. So we're actually using patients' time wisely. We can either corroborate, so maybe drill down a little bit on what we're seeing in the preference literature, or we can ask something different that we're not seeing in that literature. So it really is, they marry well together. But right now, we can't be, you know, sure that we're going to get evidence from all those sources.
That's really helpful, and I think that picks up on the issue that it depends, as in HTA in all kind of domains and sectors, it depends on the question. So different forms of evidence are appropriate for different kinds of questions, and it's for these nuances around non-health benefits, around heterogeneity. You were all saying similar things around that, and I'm going to turn to you now, Simon. Irina and Jacqueline both working in the European environment, Nancy in Canada. Are you involved in any international work that is looking at these kind of issues, at how we can more structure evaluation of patient preference studies?
Sorry, was that to me, Karen?
Yes, sorry, Simon.
Yeah, we are definitely involved in some of that work, and I've noticed even more so, as we're saying, there's lots of work going on in North America and Europe in regards to this, but a lot of the stuff I've seen recently that we've been involved in is in some of the regional aspects, even for the Asia Pacific. I've noticed a lot of focus at the moment about how those countries are evolving in terms of HTA, where those countries reside in those systems, and how advocacy is and how patients engage in those systems is quite different. And obviously the learnings that we've gained from Europe and some of the North American countries are not exactly the same, because there are some quite unique differences and challenges for some of those regional countries that are more in line with our area. So I have seen a number of those initiatives being brought up, and I think we'll see a lot more of those in the future. But I think, yeah, in terms of the global work that's going on, I think there is a fair bit and obviously a lot of overlap as well. So obviously the I Might Prefer, there's the ISPOR side of things going on as well in terms of generating guidelines and evidence and case studies. But it's not available in all countries. So I think there is still more work to be done because each country has its own challenges and opportunities as well. So, and particularly, I guess, our focus at the moment in terms of what we've been seeing is in the Asia Pacific region. There's a lot of work going on at the moment there, and obviously a lot of lack, I guess, a little bit of less of the literature and some gaps there. So we're trying to obviously work with groups in those areas to fill in some of those gaps, which is great.
And just a question for you directly, Simon, as a kind of practitioner in all of this. Somebody mentioned somewhere about how difficult it is to do the literature searching for patient preferences. Is that something that you get involved in at all? Is that something we could be developing guidance on?
Yeah, it is, because we pretty much every study we're doing, we're obviously starting off with a literature search, doing a rapid review, and sometimes it's easier than others. I think some of the groups are working on having more of a consolidated literature. I think the International Academy of Health Preference Research are working on bringing those together, which I think is a great idea, because even to Jacqueline's point earlier, is these studies are happening all the time, and a lot of the time we haven't seen them. If they're not submitted to a HTA body, they may have been published, or they may have went to a conference, but they're very hard to find in terms of you have to search country by country in a different disease area to bring that all together. But I think having some group that could bring those together and make it a little bit easier for people trying to do literature searches, and particularly I think as well, if you're an advocacy group, if you're trying to do this type of work and you want to see what's been done before, what have my counterparts in another country done, it's very hard for them to find that. And they don't have the resources to go through these expensive literature searches and paywalls and all of that type of stuff. So I think it'd be great to have a resource where they could actually look and find out what's happening in CLL, or what's happening in depression. Where can I find information on preference work in that space?
That's great. Thanks, Simon. And so the International Association, they're very important. And you mentioned ISPOR, and we should at this point say that your co-leader for the Preferences Project, Eric Lowe, sits on that task force, which is seeking to develop guidance for how to use patient preferences in HTA decision-making and regulatory decision-making. So I think that that's probably got about another 18 months to run. So a lot of work happening in this field, so that's great.
Definitely.
And just thinking about guidance again there, Irina, there's interest in the EMA qualification procedure. And could you just tell us a little bit more about that?
Yes, the EMA, actually it's a parallel EMA UNETA qualification. So EMA has standardized its procedures for qualifications, and we submitted as prefer a briefing book explaining what we would like to do in prefer and the framework we would like to develop, the methods we would like to describe, and so on, to EMA. And we asked to make it a parallel qualification procedure in order to also engage the HTA community, because obviously, as we see in this webinar, it's very important to make these kind of recommendations for both the regulators and HTA agencies. So it became a joint HTA EMA UNETA qualification procedure. We received the first batch of questions, which we discussed in a virtual face-to-face meeting with EMA and UNETA. And now we are in the process of preparing an updated briefing book responding to the questions and the concerns that EMA and UNETA had on the first version of the briefing book. So maybe referring to one of your earlier points you made, Karen, about the discrete choice experiment. Indeed, in the first instance, we focused quite a lot on discrete choice experiments because there's a lot of evidence available on discrete choice experiments and a lot less on the other methods. But of course, from the perspective of the qualification procedure, it's a bit difficult to qualify one method only, and we understood that. So it's clear that even though there is more evidence on discrete choice experiment, we should not remain blind for the other methods that are out there and that are being developed and that may even be better in specific circumstances. So we now opened up to other methodologies, and we will work out 5 different methodologies, including best worst scaling and so on. So there are 5 different methods that will be discussed. And also one of the questions was, indeed, could you provide some kind of checklist, something that we can use to judge or to assess the quality of patient preference studies? And this is also expected to be something that we will finalize in 2021. So we hope that by 2021 we will have a finalized briefing book discussed with EMA and UNETA. But again, I should maybe stress that these are not firm guidelines then coming from EMA. So this is a qualification procedure. It is a document that has a certain standing, and it can be used to develop further the guidelines for EMA and for UNETA, but these will not be the guidelines as such. So it's a document that can help, that can support the development of guidelines, but will not be the final guidelines themselves.
That's great, thank you. And a question to everybody really. I'm rolling up lots of questions in the chat. It's very busy in the question box. People really interested to understand how the patient preference information is being used. So is there a space for it in submission of evidence, either from industry or from clinicians or from patient groups? Is it just being considered, are researchers, HTA researchers, bringing it to the table where appraisal committees are considering it? Is it just a sort of informal part of the deliberative process? How is it actually working in the process? I'll start with Simon, because you're nodding your head.
Yeah, well, most of the time with us, it's a combination of a couple of those groups you mentioned. So it's either industry sponsors coming to us or advocacy groups, and that's been more common recently. And often, even if it's one or the other, the other one might be involved anyway. So particularly from an industry point of view, if an industry sponsor comes to us, we will bring the advocacy group in to work with us and form a committee to then put that through to a submission. So it seems to be coming quite regularly from those particular sources. It'd be great if it was a little bit broader in terms of it was to come, from the committee itself or from another group that it represents, in the sense that it doesn't have to be every time just a new submission comes up, but they're constantly updating, for example, their preference work for a particular area would be great. But obviously I know that there's funding and resources constraints. So obviously they rely heavily on needing sponsorship, and obviously that's where industry can work quite well. And if you bring in the patient's perspective to the advocacy groups and researchers like ourselves, then I think the hand in hand, between everyone, we can put forward the evidence to the committees and in a good light.
Okay, thank you. And Jacqueline, what happens at NICE?
Well, we're still kind of in early days, because to the best of my knowledge, we haven't actually seen this type of evidence. But we envision that it could be used in different ways. But especially if there is a good rationale to provide quantitative patient preference evidence, that it would depend a bit on the kind of the decision problem and the study at hand. But similar uses to the ones I think that Simon and Nancy outlined, I could imagine it having a kind of a supporting role as part of those deliberations.
Okay, thank you. And Nancy, is there a structured way in which it's considered at OTAC?
Well, insofar as it's a conscious consideration within their deliberative framework, as I outlined in the presentation. I think there's some other unique areas. We do accept requests for an HTA and to support a funding recommendation from anyone in Ontario, including patients. And so a patient's preference for a technology that may not be publicly funded right now can come through a request for that technology. So that really kicks off the process. And another unique area is in the procurement process, because understanding patient preferences might mean that the province might procure a certain technology within a class of technologies because of its characteristics that are important to patients. And an example would be there might be two different technologies, but one might be more compatible with an MRI. And so patients might actually prefer having a technology that's implanted in them that's more compatible to an MRI in case they need that down the road. So that whole procurement area can be influenced and informed, I think is a better expression, by patient preferences. And then I think finally, the whole genetic technology area is just ripe with needing to understand patient preferences because it borders on moving into the realm of ethics. And I think that whole area needs to be explored more. Is it preference? Is it ethics? Where does the line cross over?
That's really helpful. Thank you, Nancy. And Irina, from your reflections and what you've seen in Prefer, have you seen any areas where there's a particularly good process for the way in which patient preferences can be included in an HTA appraisal kind of process?
Well, I think if I'm speaking from, I'm taking a different hat now. I'm speaking from KCE's perspective, maybe. So that's the Belgian Health Technology Assessment Agency. I think one of the things that I see as a potential systematic role for patient preferences would be indeed to make more explicit the unmet needs of patients. I think that could be a systematic part of a reimbursement dossier as well, because that is really, for me, that's the essential part of a reimbursement decision. So you first want to know what patients do need and what their priorities are. And yeah, from my point of view, we are at KC now developing a methodology for identifying unmet medical needs in different patients groups. So a generic approach which is in first instance rather quantitative, but then gives steps towards a qualitative, more in-depth analysis of the real needs of patients. And I think that, in my view, it should be become in the future an essential element in a reimbursement dossier.
Thank you very much. We have loads of questions we haven't answered, so I can always flip those over to webinar 4 or to our future work, because we still have to decide what this project is going to go on to do after these webinars. But I think we've had a great discussion. I'm going to ask you one final question each. Obviously, this is the HTAI project group working on patient preferences. What can HTAI be doing as this international, interdisciplinary community to move this work forward, recognizing the work that everybody else is doing? What's the most important thing we in HTAI can be doing? And I'm going to come to Simon last because he's the co-leader of this project. And I'm perhaps going to start with Irina, because you've been working on lots of things in Prefer. What do you see is going to be left in Prefer that we could still be working on?
Well, I think for what I see as a potential role of HTAI is mainly, and I think the webinars are great for that, is to increase the awareness amongst the HTA agencies and other HTA doers and people who are contributing to HTA, is to really increase the awareness of the potential importance and the potential uses of patient preferences in the entire process of a medical product life cycle. And also, and you do that greatly, of course, is by inviting me to present Prefer, is to increase the awareness of the agencies about ongoing initiatives like Prefer. So it was great that I was given the opportunity to present the work that we are doing and what we hope to achieve with this work. So I'm also hoping at the same time that HTAI and the PCIG would be willing to disseminate then afterwards, once we have the recommendations towards the entire membership, what has been produced by Prefer in terms of recommendations.
I can certainly say that they will be very willing to do that. We're very willing to cooperate. That's great. Thank you, Irina.
That's good.
So Nancy, from a Canadian perspective, sort of what can HTAI be doing? Because we are international, we're not just European. What can we be doing?
Right, and there's no shortage of ground to cover, that's for sure. I would say going forward would be to include patients in the conversation that we're having here today. So if there's opportunity to have a patient as a webinar panelist in future webinars down the road, to bring their perspectives to the conversation, that would be amazing. And perhaps I wasn't able to attend the last two, and maybe that happened, and going forward perhaps that's going to be on webinar 4, but it's a great opportunity to since it's about patient preferences, to just get them into this conversation as we think about how we can continue to develop the area.
Thanks, Nancy. That's great. And we should say this is the only webinar without a patient representative because we wanted this one to be about HTA bodies, but we certainly absolutely take your point. And our co-leader is a patient expert. So that's a really, really good point. So I'm glad you made that. Thank you. Jacqueline, thoughts from you. What can HTAI be doing?
Well, I will echo what everyone else has said, but I think to add to that, it would be great if HCI could also shine some light on some of the alternatives to the DCE, because we know very well that even though that seems to be, you know, the number one approach that everyone kind of wants to use, and then there's some other stuff as well. It sometimes feels a bit like that's the situation, but we know, and that's also a big limitation that we see, that DCEs aren't always appropriate because of the type of the patient population that you're trying to elicit preferences from, or sometimes you can have sample size issues if you're talking about rare diseases. So we know that there are potential other methods out there as well, and it would be helpful if we get some more insight into those and how they measure up against some of the alternatives, including the DCE.
Great. Simon, do you want to make a comment now, or do you want to hold your fire for the final webinar?
No, I can certainly hold it. I think a lot of it's been covered already in terms of what everyone said on the panel, so that's been great. I think, you know, HTAI certainly has a place, and I think that's been coming through in all the webinars that we've done so far, that we can sort of summarize in webinar 4.
That's great. Thank you very much. That's a great segue for me to thank my speakers, to thank Adrian. And I'd also like to thank Nigel Cook, who was the inspiration for this webinar. And you will know that Nigel has really moved heaven and earth to get preferences into HTA. And we really thank him, although he's enjoying his retirement somewhere sunny. But this webinar is really a tribute to Nigel. And a huge thank you to Adrian for stepping into his shoes to co-moderate in such a wonderful way. And a reminder, in the chat box, you have the link to register to webinar 4, which is the same time wherever you are on October the 26th, and that will be led by our other co-leader, Eric Lowe, very much looking at patient organizations, involvement in preferences research, and how that advocacy role is changing, as we've heard, as Simon said, as we recognize, as patient groups recognize that they can undertake very good research that can really influence decision making, as we've heard today. So I'd like to thank you all for your openness, for your practicality, and let's keep the conversation going to make sure we raise awareness of patient preferences research in HTA. Thank you all very much.
Thank you. Thanks, everyone.
Thank you. Bye-bye.
Bye.